Okay, so our presentation today is going to be on medication safety, telehealth, and Medicare opportunities to reduce older adult preventative harm. And we've got a lineup of just incredible speakers that I am so excited for you to hear from. So we're going to get started here. And first, it's my pleasure to introduce Nancy Kozik, who is going to get us started.
Thank you so much, Danielle. I really appreciate this. Is very, very exciting. I just wanted to tell you the Partnership for Connected Illinois is a nonprofit organization in Illinois which seeks to advance telehealth and broadband adoption. And we're very, very excited to welcome you to our discussion today on medication safety, telehealth, and Medicare. I want to particularly thank the Upper Midwest Telehealth Resource Center for hosting this event. You've been a great resource over the years, and you continue to be a great leadership to telehealth and broadband in Illinois. I also want to thank the Project Patient Care Leadership, Pat Merriweather Ages, who is going to be speaking next. She has been an inspiration. She's a terrific organizer. She's a endless resource of information and quite a visionary. So we really are very, very grateful for her leadership on this. I also wanted to thank various supporting organizations that helped us publicize this event. Age Options, Connected Health Initiative, the Egyptian Area Agency on Aging, and the Illinois Office of Broadband, which has sent it out throughout the state of Illinois. This is an important topic, and it's a topic that I have a personal commitment with, or personal experience with. When Pat was telling me about the issues of multiple medications, I was reminded of the story of my dad. Go to the next slide when we're ready. And my dad was in an independent living situation for most of his later years, and there came a point where he was falling down and just having all sorts of issues, and we had to figure out, well, what do we do next? And we decided, well, we really should get him into a nursing home. What we found out when he was admitted to the nursing home is that he was on 13 medications. And the first thing that the doctor did at the nursing home is reduce that to 5 medications. And my father thrived in the nursing home, and he lived to be 92 years old, which is pretty terrific. And it's a personal experience of the issues of, like, why was my dad on 13 medications? In any case, that will be a topic of discussion for everyone here. And the idea of this event is to help seniors and their families and their caregivers reduce the risk of harm through multiple medications. Anyway, with that, I'm going to turn it over to Pat, who is our leader in this whole thing, and she'll be our moderator throughout.
Thank you, Nancy. And I just want to add on to many of you maybe in the Illinois area know Nancy. And Nancy was a state legislator, and she was instrumental in getting the telehealth initiatives to the forefront in Illinois, as well as she's a lawyer and she's worked with not-for-profits for a long period of time. So thank you, Nancy, for being here today and joining with us.
Thank
So
you so much.
why are we doing this? We're doing this because one, there's an opportunity for all Medicare beneficiaries to really take advantage of this initiative. 9 out of 10 Medicare beneficiaries, those 65 and older, are on one medication, a medication prescription. And then you look at the 43% are taking 5 or more. It is not unusual for people to be on, as Nancy mentioned, 13 or more medications. And this is why Medicare says, hey, let's look at this. So the high risk population certainly is the 65 and older. and those that are on multiple medications. The opportunity for errors is significant. And that is when we don't have the right records of the medications that a patient should be on or is on. And sometimes people forget that, the over-the-counter medications, the different types of vitamins and supplements really have an effect. So again, we take a pause and we do a look at every year, looking at what medications Medicare beneficiaries are on, but it's discussing it with them and knowing the why they're on the medication. So again, there's many ways that errors occur, but if we can reduce the amount of errors for patients, it would be tremendous in terms of their life expectancy and the harm sometimes that occurs. Now, the objectives are we want to make sure that everyone knows they should have a copy of their prescription medications, over the counter, vitamins, and supplements. We hope you leave with that message because if you ever, if you change your Medicare Advantage plans, sometimes the medications don't all get transferred over. If you're in a Medicare Advantage plan or Medicare, but you change your primary care physician, that is also another time when there's a slippage in terms of the information. So we hope you'll make your annual wellness visit, and then we'll talk about the comprehensive medication review because both of these are critical for Medicare beneficiaries, knowing 90% of them are on some sort of medication. And then deprescribing. Deprescribing is a wonderful tool. And you just heard a story from Nancy from going from 13 medications down to 5 medications and feeling great and living to the great age of 92. So, and we're going to talk about how to avoid medication errors while you're in the hospital or when you're leaving the hospital. So with that, I'm now going to turn it over to Nicole Brandt. Nicole Brandt, many of you may not know her, but we all know her in healthcare. She's actually with the University of Maryland, the School of Pharmacy. She's has directed so many initiatives, including the Peter Lamy Center. I have to say, I've worked with Nicole for several years, and she's amazing. She's in geriatrics, the older aging population, and just has a real knack for working with older adults and making progress. So with that, I'm going to turn it over to Nicole.
Awesome. Thank you, Pat, and thank you for this invitation today. And welcome for those of you joining us or listening to this program later. As Pat mentioned, I have been working in geriatrics and aging programs for my whole career. And I've dedicated my career to improving medication safety, especially through our research, our public policy and advocacy, our clinical training programs, and today, clinical service. So if there's a little bit of background noise, we're actually at a senior community doing what I'm going to talk about today, annual wellness visits. So we have an interprofessional team at the University of Maryland, Baltimore. It's a graduate level campus where we have the schools of pharmacy, nursing, medicine, social work, dental, as well as law and physical therapy. And we pride ourselves in terms of training our workforce together, but also improving our community's wellness. And so we do wellness clinics in some of our low income housing sites throughout West Baltimore, which is in Baltimore City, as well as Baltimore County. So, like many people in healthcare, we wear many hats. So, today I'm going to talk about it from a clinician perspective, but I also have the privilege of doing some work and have done some work with the Centers for Medicare and Medicaid Services, which is just up the road. And you'll be hearing from Dr. Brian Isitz. So, a little bit about annual wellness visits. So, as you can see here, this is an older adult in one of our communities, and we do annual wellness visits on site. Now, annual wellness visits are for those who have Medicare Part B, and they have to have it at least 12 months. And they can get this welcome to Medicare visit, but the timing is usually either the welcome, which is your initial visit, or 12 months later. So it's an annual benefit that you can get. There's no cost to the patient if the provider, your doctor, accepts the assignment. And let me tell you, I'm not talking about reimbursement, but it is a good reimbursable program for people that are in the community, what we call ambulatory care settings. So this is a really kept secret. We actually did a focus group several years ago with older adults and asking them about annual wellness visits. And they say, well, I see my doctor, but I don't know if I've ever got one of these annual wellness visits. Well, you'll know if you get an annual wellness visit because it's not going in with a complaint, but it's really a wellness checkup. So there's high risk assessments that are done, which are completed by the patient, covering things such as your social behaviors, drinking, maybe smoking, your exercise. So we ask about that, and other types of things you might not be doing in terms of getting your vaccinations or wearing a seatbelt or eating well. We also get a family and medical history, and this is a review through the medical records as well as obtaining it from the patient themselves. We get a comprehensive medication list, and we know that medications are often prescribed by multiple providers, which is really important. And these medications, as Pat mentioned, are not just the prescribed medications, but these are over-the-counter medications. And this is really vital because as you saw prescription medication use, the use of over-the-counters, herbal products, vitamins, other types of remedies are increasingly more commonly used by older adults. And one of the things that I think is really imperative to ask about in terms of medication taking behaviors, not just the smoking and the drinking, but cannabis use, because cannabis, CBDs or cannabinoids and THC also have medicinal properties and interact. So lots of things that we need to ask about when we're getting a history. Especially on the initial visit and subsequent visits, we'll take their weight, blood pressure, and height, because that helps to calculate some of the risk indices, especially in terms of weight and BMI. We'll screen for cognition, and these are different tools that you can use. And we've been using and actually testing. We just published an article testing different tools to be used in different communities where the literacy may be lower. And so there's some screening tools that are out there. And then preventative care. Creating a schedule for future care needs, such as eye exams, hearing assessments. We screen for hearing, as well as vaccines. We do a lot of vaccine promotion in our communities. Actually, we're just submitted a paper about vaccines in our low-income housing, about developing trust, and because we're caring for primarily 86% of the population we care for are Black older Americans, but we still have a vaccine rate of about 65%, which is quite high because of trust and the understanding of community and preventative care. In terms of health advice, I just did 2 diabetes educations today. We do a lot of blood pressure monitoring and screening, foot care, ear care, basic programs that can help. To learn more about annual wellness visits, again, this is a benefit that people should be utilizing with their healthcare team, and you can find more through the CMS website. So just kind of alluding a little bit to our program, we've been doing this program as part of our community wellness and service. We've also realized that this is a vital time to talk about advanced directives. So we complete an advanced directives during these encounters. We take it one step further and we identify goals for the upcoming year. This has been particularly enriching for us as providers who've now been here for 3 years to see where we're meeting those goals. But more importantly, the empowerment, the engagement of people in their wellness is so important. And we've actually seen from our work by having these wellness clinics on site, we're extending them living at the housing sites longer, which we know, at least in my state of Maryland, public housing and affordable housing and having higher level of care sites is not easy to come by. So this is really, we've been very excited by it. So I'm just going to share a little bit of a story. This is part of our team during some of our efforts. We're really embedded in the community, but this was I would call it a young, older individual, a 67-year-old woman who is accompanied by her partner of 30 years. Her partner is her primary caregiver. So oftentimes we're seeing people with their primary caregiver. And this person was a retired nurse. She was worried about her loved one being kind of like Nancy was alluding to, worried that she might be taking too many medications. And what could we do to help make her medications safer to both oversee, but also are there many medications, and we're going to talk a little bit, that we could potentially deprescribe. So I know that this is not a talk about all different types of medicines, but I just put this list up here. This is actually a list we created to try to look at timing of medicines from a management perspective. So there's a lot of medications for her mental wellness with a history of depression, anxiety, sleep disturbances, as well as other coexisting comorbidities. So a lot of different medications that could, one, increase the risk of falls, potentially increase the risk of confusion in a 67-year-old person. So there's a lot of opportunity to, I like to say, deprescribe or optimize the medication regimen. So for those of you who are not familiar with deprescribing, deprescribing is a framework. It's a systematic, structured approach to identifying and discontinuing or reducing medications when their harms outweigh their benefits. And this is in the context of individuals' patients' goals, values, and clinical circumstances. I say that because sometimes our patients stop and start medications because they may perceive they don't need them, which is not a healthy behavior to have, especially from a safety and chronic disease management, where some of these medications could cause harm when they stop them abruptly. And that's why I say to patients, deprescribing is something you need to do in coordination with your medical team. And there's various approaches to that in terms of how to manage it, but it really needs to be based on what matters to the patients in terms of goals of care, as well as the clinical circumstances, because you wouldn't want to stop a medication abruptly and cause potentially more harm. So there's been a plethora of increasing number of clinical trials and studies looking on how best to deprescribe. I'm also mindful of my time. But this is something ARC put together an approach, and they put together protocols. Hyperpolypharmacy is when, Pat talked about 5 or more medications. Hyperpolypharmacy is 10 or more medications. And we know as we increase the number of medications, we increase the risk of adverse effects or drug-drug interactions. You'll hear one of my colleagues talk about medication reconciliation. And this is really important, understanding why patients are taking the medicines. Are these appropriate medications for them? Is it an adequate duration of use, or they've been on it too long and they really don't need this medication anymore? And then looking at complexity, just like you saw with the patient case from before. These conversations, but really a clinician taking the time to look at the benefits and harms and making sure that there's not a major interaction going on or the person isn't experiencing some sort of side effect. And then through shared decision-making, prioritizing what we should deprescribe. And I think that's really important, is that there's not just one approach. It needs to be prioritized based on the patient and what their goals of care are and their opinions about what matters to them with what they want to be treated with. I always say, just as you're starting a medication, ideally you start one at one time so you can monitor it for safety and efficacy. The same is with tapering or deprescribing medications, doing one medication at one time so you're not unsure of what medication might be causing the problem. Documentation is so critical in terms of helping to follow up. So just as we prescribe and monitor, when we deprescribe, we need to monitor. We need to communicate with all providers to let them know that this is happening, and communicate with the family members, not just the patient themselves, because sometimes the family members are picking up medicines or helping to contribute to the polypharmacy problem. So a lot of opportunity for education here. These are some tools that I think are really pivotal, because depending on the medication that we're trying to taper and discontinue, we might need to be very explicit. So some medications, such as benzodiazepines that we commonly use for anxiety or sleep, we have to be very explicit on how we want to taper so we don't cause the patient going into an adverse drug withdrawal event. So our colleagues in Canada have put together some wonderful resources, and all of these you'll see are on one of the slides I'll reference in terms of references. Now, it sounds very simple, but there's many challenges with deprescribing. We know that our patients are seeing multiple providers, they're using multiple pharmacies, they're self-medicating from ordering things off the internet, sometimes even getting medicines from different countries due to affordability. So really understanding and communicating. I've been privileged to work as part of a US deprescribing research network. I realize that the word deprescribing itself may not be culturally accepted by some communities. And so I always like to say the right medicine for you. And I think, Pat, you might remember that when we talked about the Elder Care Medicine Network. We also need to navigate the uncertainty about the benefits and harms. So when you're having those shared decisions with patients about that, is trying to understand their perspective of where they're getting information about benefits and harms, and then why they might be afraid of stopping medications. I see this a lot of time with diabetes medicines. Well, I'm told I'll need this medicine for life, but they might be losing weight, not eating well, their goals of care have changed, and again, liberalizing what we're trying to treat. And that's where the conversation about life expectancy and prognosis comes into play, which is never an easy conversation to have, but it's something that we need as clinicians to be mindful of where people are in their goals of care and their life expectancy. One of the things as a pharmacist to be very mindful of, I always look for withdrawal symptoms. We could talk about adverse drug events, but there's adverse drug withdrawal events. So again, how do we stop these medications or taper them off? The other thing that I've seen misadventures with is not conveying these stop orders to the pharmacy. So sometimes systems have things in place like cancel RX, where if the doctor stops it, it'll send a cancel order. That doesn't exist everywhere. So sometimes calling the pharmacies to ensure that the medicines are stopped are an important aspect too, so they're not continued. So I like to frame this. I've been doing a lot of work with age-friendly health systems, age-friendly ecosystems, age-friendly pharmacies, and it's the forums. What matters to patients: mobility, cementation, and medication. And I know here on a state level, we've been using this in a lot of our advocacy work when we're trying to help engage our older adults with the caregivers and with some of the policies and programs in our state. So shared decision-making is really important. And then just to take this a little bit further, this has been a great resource. We take this to our communities. It's called My Health Checklist. This was developed by the Institute for Healthcare Improvement through a project called the Conversation Project. This tool is free. I'll say it again, this tool is free. It is available in about 27 different languages. Maybe there's even more now. We've been using it when we go out to our communities. We actually put together a video promoting how we've been using it in our communities. And it's just really, again, about empowering the patient to be a part of their journey with their health and wellness. So, and the US Deprescribing Research Network, highly recommend. Pat, I want to say again, a big thank you to Pat, who's been a partner, and a thank you to Dr. Isitz for introducing us in our work, but she's joining our US Deprescribing Research Network as a stakeholder member, and myself, Dr. Steinman, and Dr. Boyd, two geriatricians, were just quoted recently in the Wall Street Journal based on a case from my practice at the hospital system, where someone was over medicated, and what can we do about it? So again, the philosophy of deprescribing. And then for those of you out here who want to get trained more, we've been doing work on promoting age-friendly pharmacists and age-friendly pharmacies, and this resource is out there as well. So I just want to say thank you. This couldn't be done without a team, and we continue to do this work in our communities. So with that, I hopefully stayed on time, and I'm going to turn this over to my colleague and friend, Dr. Isitz.
Thank you, Nicole, for everything that you've done, and it's great to see you also in action.
Thank you. Thank you,
And
Pat.
at the
Yes.
site. And now we're going to hear from Dr. Brian Isitz. He's the professor emeritus at the University of Minnesota College of Pharmacy. And he's also, many people know him as sort of like the grandfather of comprehensive medication review. And speaking of grandfather, he's a second time grandfather just this week. So congratulations and thank you for all you do, Brian.
Well, you're too kind, Pat. So thank you so much. And it really is a pleasure to work with you again, Pat. We first got a chance to meet almost 15 years ago, shortly after the Affordable Care Act was passed, and I was happened to take a sabbatical to go to a small payer in Baltimore, Maryland, which you've heard about the Centers for Medicare and Medicaid Services. And actually, I ended up staying 3 years at the invitation of President Barack Obama's administration. And we actually worked very closely on medication safety and specifically about what matters most to patients. And that's what I learned so much. And in fact, Dr. Brandt did a number of focus groups that have persist to this day of their importance. So the title of this short section is Managing Medications Confidently, what older adults and caregivers need to know. So our objectives here are to describe the need for a rational process to help patients and family caregivers make sense of taking medications, provide an overview of how we are learning from people who are successfully managing their medications. I know, what a novel idea. We're actually listening to people, what they need to know and where they need help. And then we're going to present a new approach that has been proven to help patients and family caregivers confidently self-manage their medications, what I think is a major step forward. And then discuss steps, strategies, and resources that are available to help you confidently self-manage medications. Now, as we go through the next few minutes, here are the drivers or questions that I want that we should probably running through our head. How and why has the process of taking medications become so complex? Why does it have to be so difficult? What are we doing to understand what matters to individuals to help us all make sense of taking medications? And how can we collaborate more effectively with patients and family caregivers to help to confidently self-manage medications? Now, before I go to the next slide, let me warn you, the initial impression may be disturbing. This is an actual patient. Now, I'm going to ask you, what's the first thing that goes through your mind when you see this picture? What if you were that patient taking these medications? Well, the purpose of this photograph is symbolic for this presentation because where this patient was previously was way more medications than you see before you. And at the end of this journey, this patient knew that all those medicines had an intended medical use. They were working for that patient, they were safe, and they knew how to take and afford them. That's the journey we're going to go on. That's what every patient who may need to take medications, it's where we need to end up. And we're going to show you how we're planning to get there. I talked briefly about the symptoms of a dysfunctional medication use system. And I should put the word system in quotes because system implies that some engineer designed this consciously. But I would like to meet that engineer who designed the so-called system we have right now. Because we spend over $500 billion, that's with a B, annually to fix the bad things that happen from medications. And this just isn't just the side effects and adverse drug reactions. It's the fact that patient may be on the wrong medication and or they are doubling up on their medication or they're not getting the benefits because they can't afford them, so they have to go to the hospital or the emergency room, and this racks up expenses. Now, these medication side effects are the most common reason for hospital readmissions, the ineffective use of medications. And what's interesting is, as I sift through some of the television advertising, it seems as though all the bad things that happen from the taking medications are a tolerable cost of doing business. And I'm scratching my head when they go through all the side effects. What's the last side effect that's very commonly they mention? Yeah, death. and I got to get me some of this drug. I'm still baffled to this day of the value of those television advertising. And here's the root cause of the dysfunctional medication use system. It's because people don't know the reason why they're taking each medication, how each is supposed to work for them, which side effects are specific to them, and how to take and afford their medications. So how are we going to address this? So here's the story about having patients teach us what matters most when taking medications. At the end of the day, the story is this. We want to make sure we're ensuring the medical necessity, the reason for taking the medicines, trusting that they will work. They have a clear understanding of side effects and knowing how to take and afford them. What's also important is this open communications with the health team. We all know that for those of us who are healthcare professionals, we all know about the gaps in communication, how busy we are, the shortage of practitioners, but that open communication so that everyone's on the same page is so critical. Well, so the patients want to make sure that we minimize disruptions to daily life. Here, Dr. Brandt just showed you a medication chart of the different times of day that a person's taking a medication. Can some of those be collapsed down maybe into twice a day instead of 4 times a day? And then we have done studies, actually from our nursing colleagues, learning from those who are successfully managing medications. And what we've learned is that the individuals who are successful have established habits to organize how they think about medications. And this word organize is critical because it's a new organizational paradigm of how we think about taking medications. They value medications that they will work, and there's confidence that there will be collaboration with providers to keep it simple. All right, so how do we make sense of taking medications? Well, one approach is thinking, I call it thinking like a pharmacist. Because prior to 1990, we did not have a systematic process to assess the appropriateness of taking medications. You might have gone to a physician, a cardiac physician, and they evaluated the appropriateness of your cardiac medications or your respiratory medicines for a pulmonologist or something else. But as I say to my patients, when does somebody bring Humpty Dumpty back together again? Okay, and so we developed this pharmacotherapy patient care process to systematically assess indication, effectiveness, safety, and convenience of use. And in that order is critical. And this process has been demonstrated to improve clinical, economic, and humanistic outcomes. I'll go through some of those outcome measures in a minute. And so that before taking a drug, the patient, the same way I think when I go through a systematic assessment with a patient, it starts with knowing the intended medical reason for taking each medicine, how it's supposed to work, what safety concerns are to know and watch for, and how to take and afford this consistent and orderly four-step patient care process. So how can we build that and embed that into everyday lives of the patients we serve? So this outcomes research has supported this four-step organizational approach. Now, you may hear the terms comprehensive medication review. We'll talk about that here in just a minute in terms of the Medicare Part D as in dog drug benefit. You also hear the term medication therapy management services, or these MTM services are actually then recognized by the American Medical Association in the current procedural terminology, or they have CPT codes. Has been demonstrated to reduce hospital readmissions and admissions, as well as emergency room visits. Obviously, reductions in adverse drug events. We have demonstrated consistent improvements in clinical outcomes. Patients with diabetes, decreased blood sugars and improved hemoglobin A1C values. Those with high blood pressure, hypertension, improved blood pressure, cholesterol, right down the line. And it has this positive return on investment. So for every $1 invested on the infrastructure for this comprehensive medication management, it saves at least $4. And of course, decreased total costs of care, improvements in health-related quality of life. As patients become more confident that it's working, it fits into their life better, it improves their quality of life. Increased patient satisfaction with care. Another one is actually it increases physician joy in work. Increases physician joy at work. We've measured this as though, for instance, the doctor may be able to go home a half an hour earlier each day because the patients are well managed. And of course, the increased patient confidence in self-management. All right, so here's what I'd like to highlight today. And this was developed through the Minnesota Geriatric Workforce Enhancement Program, which I am a member of the Minnesota group. The Geriatric Workforce Enhancement Program is funded through the Health Resources and Services Administration, HRSA. And now we're on the second of two 5-year cycles. About 40 of these GWEP or Geriatric Workforce Enhancement Program grants across the nation. And what I have provided you is a link, and I'm hoping that Danielle will put the link in the chat as well so that you can copy it and save it. Because what I have here is this, it's a self-paced digital training module with animated patient cases, resource links, and self-efficacy checklist. Now, let me just caution you, when you do view the animated patient case, it's not an AI generated avatar. It's a little less technologically developed. So you may chuckle when you see it. It's almost a little bit of a cartoon. But the most important thing is it highlights one of the most common situations that I see in practice, this prescribing cascade. So a patient started on a high blood pressure medicine, didn't have to be on that. All right. And it actually was a white coat hypertension, we call it. When they go into a clinic, their blood pressure goes up. So that's not working. They send them to another doctor. They add another drug. All right. Then they put them on a diuretic. The diuretic causes the person to go to the bathroom all night. So they give them a sleeping pill. And it just goes on and on until we stop the madness and go back to the beginning to assess in systematic order indication, effectiveness, safety, and convenience. Now, these toolkits that we develop through the Geriatric Workforce Enhancement Program are intended for healthcare teams. And this particular one has a dual purpose, both the healthcare teams, so that we all think the same way through this systematic 4-step process, and for persons and families. So all of the information is to help individuals make sense of taking medications using a systematic process. So as I said, you hear the message over and over. If a person needs help understanding why they're taking medication, there are resources for that. Or understand how it's supposed to work for them. Or some of the safety and ways to best take and afford the medication. So the toolkit serves as a roadmap for interprofessional care teams to help to focus their help, as well as for patients. So, yeah, we developed this toolkit, and you might say, well, Dr. Isaac, so that's all fine and dandy. Does it make any sense? The so what question. Well, we tested this novel approach for making sense of taking medications through focus groups. And actually, over the last 2 years, have 7 focus groups have been convened at senior living centers and in low-income housing buildings. 2 of these focus groups were in Minnesota and 5 in the state of Virginia. And so really we started out the focus groups much the way we started today, an overview of why and how the toolkit was developed, this overview of the disarray we've had in taking medications. We then described the systematic 4-step process, and then we got a chance to preview this animated prescribing cascade scenario I just mentioned. And one of the things that we did then is that after we showed that, we went around the room and then asked each individual in the room to describe an unfortunate situation of taking medications. And they would tell us the story, and we translate that story back to them into one of these 4 areas of intended use, problems with effectiveness, safety, or ability to take and afford the medications. And that really helped those individuals to sink in, to understand how this tool can be used. So the feasibility testing of this shows that it does work. So across these 7 focus groups, there were 79 respondents, ages 54 to 97. And 77 of the 79 responded yes to the research question that they perceive that this 4-step process can help older persons confidently self-manage their medications. We also have a 7-item self-efficacy checklist we developed that are built around these 4, basically the 4 main questions. Do I understand the intended use for each of my medicines? A scale of 0 to 10. Do I understand how my medicines are supposed to work for me? Write down the list. And we then measure the internal consistency reliability at a very high, a Cronbach's alpha of 0.82. 82 is very good. And so really what that means is that this checklist that's in the toolkit it measures what it's intended to. But most importantly, at the end of the focus groups, a lot of key insights came forward. And the one that really got me on the very first focus group was, I said, any questions? And the patient raised her hand and she said, Dr. Isaacs, did you tell us that this process or way to think about taking medications has been around for 30 years? I said, yes. And she said, why haven't we heard about this sooner? And it stopped me in my tracks. I mean, it's like somebody tugging at your inner fabric. It's like half of me said, well, I'm sorry, I should have done this earlier. The other half of me said, well, let's get going. Let's use the what I call the Johnny Appleseed methodology and get it out here to the rest of the world. And then one of the other observations that really encapsulated much of the sentiment was, I'm relieved that I know what I'm doing taking medications. You may not know at first, but after we do the comprehensive assessment, we find out that 4 or 5 conditions you're doing wonderful. We might do some tweaks on the last one, for instance, maybe some deprescribing or changing some of the doses. So let's give some examples here of where you'll see these comprehensive medication reviews and medication therapy management visits in order. You heard Dr. Brandt talk about the annual wellness visit. It hits near and dear to me because I just crossed over to the other side, and in 2 weeks I'll have my very first Welcome to Medicare visit. So I'll be able to share some insights from the patient perspective side real soon. And as Dr. Brandt said, it's a conversation-based preventive visit for all Medicare beneficiaries, not a traditional physical exam. Looking at reviewing the health risks, cognition, medical history. Now, the medication review, as Dr. Brandt said, evaluates all your drugs, vitamins, and supplements. And all the literature says bring them in with you. So, for those of you practitioners here, physicians, nurses, pharmacists, others who will be conducting these annual wellness reviews, the patient brings their medications in. Okay, let's say you had a patient like you saw in slide number 4. Well, the first thing I'd recommend is that you get a bigger table. Okay, but second of all, where do you start? And this is where I help patients and their families say where to start. Okay, let's take all your drugs for your cardiovascular system. Your heart drugs, let's put them over here in one pile. Let's take all your for your breathing, your pulmonology medicines, put them over here. And one of the analogies I use, you've heard, I have a lot of corny analogies that I use with my students as well as patients and colleagues, is that it's the like you're playing a solitaire, the card game solitaire. When you move everything into clubs or different suits, diamonds, and what have you. The same thing. Let's start with the medications for their intended purpose, and then work down through our systematic process. So get a bigger table, but then we'll use this to then begin to organize the medications. All right, so comprehensive medication reviews in the Medicare Part D program. Now, the Medicare Part D drug program does cover these comprehensive medication reviews for, of course, I say eligible beneficiaries. So the annual wellness visit, all right, that's all patients and at no cost. These comprehensive medication reviews are also at no cost. However, the beneficiaries have to meet certain criteria, a number of multiple medications for multiple conditions and for fairly high annual drug costs. So this is where you may have to work with the health plan that you have to find out, are you eligible and how do you get one of these comprehensive medication reviews? Can be done by a pharmacist or other healthcare professionals. It is an interactive consultation, which means you don't necessarily have to come in, but you can. It can be by Zoom, doesn't have to. A lot of the assessments I do are over the telephone, which seem to work very well. And so we're really talking about the consultation on the intended use, effectiveness, safety, and cost of medication, and intended to empower patients to self-manage their medicines. At the end of that comprehensive medication review, the patients receive a medication action plan with a list of the drugs exactly the way you're taking them that day, and for the intended medical reason that you're taking them, plus any recommendations that we had discussed to improve care. I also want to talk about, for those of us who may work in long-term care facilities or have loved ones, is actually there are medication reviews in these long-term care facilities. In 1974, regulations were passed by the CMS mandating that they employ a consultant pharmacist to perform monthly drug regimen reviews for every resident. They're not paying pharmacists directly, but they're paying the nursing home, but then to pay the pharmacist. And the reason for this regulation was because at the time there was the concern about chemical straitjackets. We're giving medicines to older adults, and they're fogged over. Well, with psychotropics and antipsychotic medications, which continues to be a concern today. And it's intended to improve safety by identifying unnecessary drugs, adverse effects, duplication, allergies, and irregularities. Now, these consultant pharmacist recommendations have been demonstrated to lead to health improvements in high performing skilled nursing facilities. And I put that in as a qualifier because let's talk about quality. And as many of you may know or may not know, that these programs there's a 5-star rating from CMS. 5 stars. If you're a 5-star facility, it's like a 5-star Uber rating. Okay, that's fantastic. 1 star is the worst. Now, in Illinois, there is reading the latest data that from 2003, I believe, that 670 facilities in Illinois were rated by CMS. 75 of those earned a 5-star rating, but 250 received a 1-star rating, which is not good at all. And quite frankly, that the state of Illinois skilled nursing facility overall ratings rate in the lower third of the nation. And one other observation here is that this is kind of brand new, and I haven't been able to make sense of this, is that health plans are starting to pay for these Part D comprehensive medication reviews in skilled nursing facilities. So here I am calling a patient in a skilled nursing facility, and on the back of my head, I'm scratching my head. Well, don't you have a consultant pharmacist there already? And there's some subtle challenges that are in here. Part of it relates to the fact that if you're paying a pharmacist through the bundled payment that goes to the skilled nursing facility, that may be a perverse incentive to not do a very good job, to do it fast or do it under the cover of darkness. Because when I go into a nursing home, I make sure that I go on a day that maybe physicians are there, that all the nursing staff are all there, so we can then work collaboratively. So those are some tips as you look at the nursing home. Does that consultant pharmacist show up during the daytime when staff are there, or is this conducted during the cover of darkness? So, in conclusion, then, the process of taking medications has become overly complex, and it doesn't have to be that way. We haven't designed a medication use system from the end user's perspective until now. We're learning from individuals who have mastered medication self-management on their own, and it's really by knowing why you're taking each medication, what it's supposed to do for you, which side effects are specific to you, and how to take and afford each medication, so that you will be able to confidently adjust routines, simplify schedules, manage costs, and collaborate with your healthcare team. And with that, I'll turn the program back to Pat. And I do have my contact information for those of you who may want to contact me after the show today.
Thank you, Brian. And again, what a comprehensive approach to this. I always learn so much from you. And I have to say, this is a very valuable resource that you have, that anyone that qualifies can be taking advantage of. But I sometimes wonder why people don't take advantage of it. I think they think there's a cost associated with it, but Medicare has provided this free. And the Medicare Advantage plans provide it free. And it's really a valuable resource. And I have to say, when you talked about people being on different medications and then changing, trying to make some changes, sometimes the people, patients don't have the medications that they're on. And so having that list, having that information is critical to have with them. Because if you ever need to go into a hospital, that's certainly important, and especially if you're not really cognizant of what's going on. So again, just a great sense of tips that you and Nicole have provided. And now I'm going to turn it over to Kirsten Weber Todorellis of Atelis Health Advisory, but she also is recently, she was the head of clinical systems for Advocate Health, overseeing 67 hospitals for pharmacy. And if you have any questions for any of our speakers, you can put them in the chat and we'll be able to answer them as we go along. So, Kirsten, thank you so much, and I'll turn it over to you.
All right, excellent. Thank you all today. And I'll try to make up some time here for the end of this to allow for questions. So I think even to further simplify me, for the last 15 to 20 years, I'm a clinician by background, actively a clinical pharmacist in the acute care hospital setting. Most recently, I've been in executive leadership positions where I've had the honor of being able to really push forward with designing virtual programs, especially virtual pharmacy programs that help specifically target some of the topics we're talking about today. So putting and extending clinical pharmacy services to allow for important services for our patients, including medication reconciliation on admission and discharge. And so we're going to talk a little bit more about what that means for us as patients and caregivers. So that's my professional side. I think what's really important, though, is that I'm also a caregiver. I am a caregiver of 4 children. I have a 7 to 16-year-old, and I'm a caregiver of a mother who lives at a long-term care facility with an atypical dementia. I think you're going to also learn that I am also participated in healthcare decision-making for my late grandmother in a story that I'll tell a little bit later today, which drives some of my passion for this work. So I'm deeply and actively involved in the advocacy of this space, as well as a clinician in it. So we're going to be talking about medication reconciliation across care transitions, understanding the importance of your hospital transition process. And so why is this so important? 50% of medication errors occur at the point of care transition. Transitions are where medication lists change quickly. So that stagnant list you may come in and changes multiple times during the course of a hospital admission. Communication gaps often occur, and errors are most likely at those points in time. Poor communication at discharge is in fact a major contributor to preventable harm. Nearly 20% of Medicare patients experience an adverse event after discharge when they go home, with over 2/3 of post-discharge adverse events being medication-related. 1 in 5 of these are preventable. It's a pretty significant statistic. Medications are a major and preventable driver of emergency department visits and readmissions, specifically in older adults, with nearly 1 in 10 readmitted due to medication-related issues. Older adults are particularly vulnerable for all the reasons that Brian and Nicole talked about polypharmacy and high-risk medication use. Older adults, as we already discussed, typically take over 5+ medications. Adults over 65 account for over 35% of all prescriptions dispensed in the United States. The more we take, the greater the risk, as we've already sort of talked about. When we look at the medication review and reconciliation process, we've touched on the comprehensive medication review already, but just as a really important reminder, especially as you go to pivotal points like a procedure and you go into the OR, these are planned visits as well, but at the point that you're entering into a unique environment or a transition point, it is ensuring that it's the right medication, right dose, right time of administration, and right reason for use, including the duration for that use. There are important points that this should occur on admission, on any care transition. So that could be you come into the OR, but then you end up on a floor unit, or that floor unit goes to a rehab unit. At any one of those points, a reconciliation should occur. And then on discharge, as we just talked about, is a really, really pivotal point, as well as post-discharge, and as both Nicole and Brian talked about in that clinic setting. This is so important because it ensures that the medications are safe, effective, and appropriate at all points of time of care. The right medication today may not be the right medication tomorrow, and your body changes significantly during the course of any hospitalization. That's very important to assess. Addressing adherence and affordability allows for the addressing of adherence and affordability at each of those pivotal points. And it allows for patient education and shared decision-making, as we already talked about. Cost-related non-adherence, it affects up to 1 in 4 of our older adults, and it is a very real issue when patients aren't able to participate in the process of their care. So why older adults are more vulnerable? We've talked about polypharmacy being a huge issue. Care fragmentation is a notable issue, and you think about the concept of a hospitalization just adding to that. Typically, when you're hospitalized, you have multiple specialists seeing you at any point in time. And frankly, even as a hospital administrator, it's highly complex and very confusing. You have many hands in the pot, and when care is fragmented, medication lists become fragmented too. You have multiple transition points or handoffs in that care setting, and multiple providers making a lack of one shared medication list visibly difficult, and duplication and interaction risk increasing. You also have age-related physiological changes that are either occurring acutely in the hospital or that may actually end up being permanent. Things like kidney or liver function changes that are really important to how your medications are processed may happen during a hospitalization or even following, and they may resolve. That all needs to be looked at over the care continuum process. Older adults, as we talked about, are more sensitive to medications at certain periods of time on their care journey, and that needs to be evaluated. Cognitive, sensory, and cost barriers are a real issue in our older adult population. Frankly, patients cannot follow a plan that they cannot hear, that they cannot see, understand, or afford. And so this gives the opportunity at these critical points of care to evaluate and assess how to adapt those plans for our patients. Here are some examples of acute issues that we commonly see during hospitalization in our older adults. Duplicate medications can often impair or further impair changes in organ function or amplify other side effects of medications. Oftentimes we see a stoppage of blood thinners, which can increase the risk of blood clots or stroke. Adding on or overprescribing of sedatives can lead to delirium or falls in our patients. And insulin mismanagement is known because of our older adults are more sensitive to these agents, can lead to hypoglycemia. I do want to take a second to call attention to the beautiful woman on the right-hand side of the screen. I'd like to just sort of share a brief story about her. So she is my grandmother, affectionately known in our family as Gigi. She was 95 in this picture, holding my youngest child, newborn at the time, and one of the last times I was able to be with her for a picture. She was hospitalized shortly after for a urinary tract infection, a common infection in our older adults. She was discharged to a skilled nursing facility for some rehab and to recover. Her medications were not reconciled on discharge, and that she had been taking before admission, and that when she left the hospital. Furthermore, when she was received by the skilled nursing facility, her medications were not reconciled at that point either, meaning no medication lists were reviewed before or after her admission to the skilled nursing facility. Everything from prior to admission and her hospitalization were continued. This resulted in duplication of very important medications, including a blood pressure medication, one that also affects heart function. Upon visiting her, I noticed she was profoundly lethargic, very forgetful, and difficult to arouse. I felt something really wasn't right, and I asked to review her medication list. I discovered the duplication, and even though the medication was stopped, Gigi never fully regained her strength or her clarity. Within the year, we lost my grandma. Though perhaps not entirely due to this specific adverse event, it absolutely impacted her ability to recover and to regain the quality of life that she had before. I share this story to just really underscore how vulnerable patients can be during this transition of care. Medication reconciliation at every transition can prevent harm and protect that quality of life. It's a personal mission I'm very passionate about, and it's really in honor of all the Gigi stories that we all have and know. So what are the best practices that we can all participate in and or advocate for to prevent this harm? From a clinician perspective, we do know, and the data supports, that pharmacy-led medication reconciliation is best practice. This includes pharmacists and pharmacy technicians who are uniquely positioned and trained to catch medication risks that others may miss. Pharmacist involvement is, the data demonstrates time and time again, the pharmacist involvement significantly reduces errors, readmissions to the hospital, and prevents harm. And as it's been stated before, less is more. Deprescribing and regimen simplification is the safest approach and one of and one of the best practices that we can provide for our patients. For our patients and caregivers, keeping an updated medication list is your greatest safety tool. It ensures that all providers have the same information. This includes, as already stated, prescription, over-the-counter supplements, and any available dosing information. Just bring that list wherever you can, wherever possible. And learn to be an advocate for yourself, or if you're a caregiver, be confident in being an advocate for the one you love. That is asking any questions. If you don't understand, ask for a clarification. There is no wrong question or answer in this scenario. I'd like to highlight two important mechanisms to accomplish these best practices. As I've already mentioned, I've worked really hard over the last decade or so to help launch a virtual clinical services program that would bring the expertise to our patients wherever they are. This can be done during the course of a hospitalization with the design and implementation of a virtual pharmacy service. So bringing those pharmacists at those critical points of care, because we know that pharmacists aren't an accessible resource in all communities, including our rural networks. Or this can be facilitated with a post-discharge video or phone interview with our patients to help identify discrepancies and duplications. This ensures patients understand medication and monitoring needs at the point that they need it the most. And this is especially valuable in the post-discharge sense, 48 to 72 hours after discharge. The data demonstrates that this helps most when patients are settled at home and they've had the opportunity to get their medications, and they may have encountered issues with acquiring or accessing medications, adverse events, or any adherence issues. So they're really prepared to have a more meaningful conversation in that 48 to 72 hour range. It also really extends our expertise. We know primary care providers are a limited resource. This helps to extend our expertise with really complex regimens in particular, and really does help our seniors in the setting of expert medication management access when local access is limited. This is rural networks, as well as our seniors have difficulty with transportation being a unique challenge in that community setting. My colleagues already spoke pretty eloquently to the Medicare medication management and transitional care management programs. And so I won't belabor those services, but to know and advocate for those services for your patients or your family member or yourself is a really important tool to make sure you bring home with you. So a couple key takeaway points for our patients and families: maintain that medication list to the best of your ability, but have it printed, have it available, a refrigerator, a nightstand. Make sure your caregiver has it so they can bring it with you if they meet you at an emergency room if that's needed. Bring your meds to your appointments if you're available, but if nothing else, you'll have that list for you. And if you're unsure, always, always ask a question. It makes you part of the decision tree for participating in your care. For our clinicians, less is more. Simplifying that regimen. The best medication is the one that they don't have to take. Utilize the experts. We call it deference to expertise. Lean out to your pharmacy teammates, your technicians, and your pharmacists. We are here for you, and we are the experts in this space to be doing this work. And prioritize reconciliation. Every single touch point, we should be looking at the comprehensive medication list and seeing what's most right for our patients. So hopefully I was able to hit on all the high points from an acute care hospital perspective and all the care transitions following. It's going to happen to all of us. And so it's important just to try to remember to advocate for yourself in this space and to be your own advocate or the advocate for those that you love. Every transition matters. Preventable harm can be reduced through teamwork, communication, and prioritize safe medication practices. And thanks to all my colleagues here today. I appreciate the time. I think back to you, Pat.
Thank you, Kirsten. Thank you, Kirsten. And again, very valuable information because the chances of somebody over 65 being hospitalized increases as they age, and having that list with them. I did have a question about how do I know if the physician deprescribes a medication? How do I know it's on my electronic health record that change has been made? That's one that sometimes slips through the cracks is How does that get adjusted? And how does the pharmacy adjust it?
I can answer that question to the best of my ability. I think part of what we experience is fragmentation in our electronic health record. So assuming that it's in one health system or one health network, you should be able to see the cancellation of that prescription in your electronic health record. I think the challenge becomes if you're seeing someone out of network or in a different network system, that's where having really good active list present and available is your best safety tool. And so there isn't always a perfect solution in our world right now with multiple different intersecting health networks and electronic health records. So having a physical list is still, unfortunately, probably your best way of managing it for your own self.
Okay. And, you know, one thing that I'll just bring up, my husband, as he was aging, he decided to double up on his calcium vitamins. And he ended up in the ER with kidney stones and caused by the more than doubling of the calcium. So how do you manage some of the understanding of the vitamins and supplements that people are taking because they have increased tremendously? And maybe we could go to a full screen so we can see all of the speakers.
Pat, Brian Isaac here. Let me address that a little bit because, as most of us know, a lot of times our patients are taking a lot more supplements and nutraceuticals and over-the-counter things than prescriptions. And part of the reason for that is because if an individual would almost rather take a non-prescription drug because that's not somebody telling me I have to take this or they're prescribing it for me. I get to make that decision. Well, unfortunately, the science is not always as or rarely as strong as the testing for prescription drugs. So pharmacists have to help to figure out what evidence is available. But be honest with us. Let's figure out, tell me exactly what you're doing. And you know what? We're non-judgmental. And it's, we're trusted. We're kind of like the pharmacist down on the corner. Well, tell me the way you're really taking the medicine so we can go through that. So we're the ones that really have that expertise to help an individual determine if their supplements have an intended use, working safe, and they can take them.
Pat, and I'll follow up on what Kirsten said and what Brian mentioned as well. So I first want to mention the deprescribing. I think it's pivotal to have a list with you at all times for all the reasons that were mentioned. I think it's also pivotal to not be using multiple pharmacies. I think that's part of the problem as well, because you might be getting medicines from a mail order pharmacy, a community pharmacy, and there's these automatic refill programs to improve adherence rates. So people are getting medicines sent to them. And so on an automatic refill. And unless a prescriber, as Kirsten mentioned, unless somebody calls the system, like whatever it's a mail order system, is because they're outside of the traditional health system, they're not going to know a medication's been discontinued. So we saw a patient just the other day. We stopped an antidepressant. Their medicines were being packaged by a local pharmacy. They got the new orders, but they didn't get the discontinuation order. So they kept packaging the medicine. So it was calling the pharmacy. So it's really important that there's communication. Sometimes that's the patient or the caregiver, but it could be a member on the team to call the providers, especially depending where the medicines are coming from. So I think that's a really important. I've had too many what I would call misadventures in deprescribing where we've stopped the medicines only to have it restarted because it got sent to them by somebody somewhere. So I think that's really important. And as Brian mentioned, over-the-counter products are being promoted in so many different venues by so many different people. And human nature is to explore different approaches. I had a woman come in with 20 supplements just the other day, and half of them were for cognition. And she was on 8 different prescription medicines, and there was a plethora of interactions. She was very skeptical. So I use a platform that other healthcare professionals may be familiar with too, Natural Medicine Pro. I shared with her the interaction report. She, who normally never calls back, called back right away. I had no idea. And I think that just speaks, and this is a very educated person in terms of the training that she had, but I think it's just the awareness that these have medicinal properties. They interact with your other substances. Dose matters, Pat. Thank you for articulating calcium, because people think, just like vitamin D, oh, I take one, I'll take more. I had a patient on literally 15,000 international units of vitamin D a day. So his level came back very high, not surprising, which can be potentially toxic. So especially over a period of time. So it's just, I think awareness is key, and we just need to make sure we include these as we're obtaining those medication histories. Brian hit on it though, trust. I hear from patients, well, I don't want to talk to my medical team about it because they don't believe in these things and they don't know anything about it. So I think we need to let them know we do, and we constantly are learning, and we're learning this together because there's so many products that are emerging out there that we need to be mindful of.
We do have a question in the Q&A for you guys. So Abigail Sage has asked, do you find that older patients like to use virtual medication review appointments? And is that becoming more common?
I can speak to that. I think that when in a coordinated sense, it is becoming more common. It can be in two mechanisms. Telephonic is also something we consider virtual. But as we have an aging population that has a lot more comfort with the iPhone or iPads, folks are becoming more comfortable. It's clearly a better experience when someone can show you your medication bottles and have a more engaging experience. But a touch point, at least telephonically, is something that has been a very positive experience for our seniors, especially in a post-discharge sense. They just left a pretty traumatic experience leaving the hospital. We do know that touching a patient immediately at the point of discharge, it adds to the confusion of the discharge experience or the hospitalization. But giving a couple days and allowing for them to settle in and then have someone follow up that they may or may not have had an interaction with prior to discharge is seen as a very positive experience. We do try to work with their technology and their skills in order to allow for that experience to take place.
What about, I know there's a note in there about, this is something I haven't heard, medication synchronization. Michael Reese
That's
has
me.
raised
That's me,
this issue.
Pat. So the question is, there's also the problem of one's medications not all being renewed at the same time. Boy, do I hate that too, if from family members and others. So that one of the programs that's been developed is called MedSync or medication synchronization. And not all insurance companies will pay for that. But I would contact when you go to your pharmacy, say, all right, it's intended for patients on 5 or more medications or what have you. Okay, can you help me enroll in Medicare medication synchronization or MedSync? And one of the things, Pat, I'll do is there's some resources available that are we going to send the slides out afterwards to the attendees?
Yes. Mm-hmm.
Okay,
Yeah.
I'll send you this link to a couple resources, okay?
Okay, that sounds great.
We have another question in the Q&A. So someone has asked, how do you suggest starting a program with the outpatient pharmacy and the hospital patients? Is there a program in place?
Yeah.
So go ahead, Kirsten, and then I'll go after you.
Yeah, sure, no problem. And that's actually a pretty complex question, to be honest. But there are a number of different ways in which that can be started. We call it meds to beds, or medication at discharge is an easy way to do a couple things. You're ensuring that you're able to run access of the patient to their medication or their prescription through their benefit plan to ensure that it's covered, that they have access to the medication, that then an affordable alternative can be prescribed before they go home. It's challenging in a hospital setting, as we know, and I've lived for a really long time. Discharge is ideal, but not always perfect. And so that's the biggest challenge in a true meds to beds program. Nationally, the statistic I think is sub 60% on our ability to hit medications to discharge, meaning we give the patient their medication before they go home. And that 60% average is exceptional. I would say it's much lower in most of our hospital facilities that have programs. I'm happy to talk more about how to set those up, and then what a truly virtual program that extends beyond that looks like, because it does wrap around those services. As we mentioned, the timing immediately at discharge to hand a patient the medication is an amazing thing. To talk to them about their patients is not the best time. And so there are sort of different facets of that program in its totality.
Nicole, did you want to add to that?
Oh, Kirsten did a fantastic job.
Okay.
We have a bit of a different approach. It was more of our practice working with a local pharmacy. We pride ourselves in terms of caring for some of the most complex and individuals that have cognitive issues. So medication management is a big issue. So we've been working with local community pharmacies to help with this long-term care pharmacy at home, which helps package medicines, provides medicine reviews and services. And it's paid by most Medicare Part D payers, but not all equitably. And I think that's something as we talk about these programs is ensuring access to these programs that help people age in place. And we know medication management is one of them. So, but I've been navigating that through some of our work with local pharmacies that really provide services that help go above and beyond. And we know that, as been already mentioned, that transitions of care are a pivotal time. So not all hospitals in our area do meds to beds. It's increasingly common, but there's other things that need to be done besides just the bedside to ensure continuity of medicines as well. So just want to mention that, Pat, because it's another CMS program through Medicare, but there are some qualifications, eligibility, and again, some disparity in payment amongst the Part D providers.
Thank you. Do the speakers want to have any final comments on, if you could wave a magic wand, what would you be telling patients they should be doing in being cared for?
If I could wave a magic wand, Pat, I would make medicines more affordable and the services that could surround their appropriateness more accessible. I think I commend the team here for promoting telehealth programs because it does improve accessibility, but I think coordination is critical. And I think communication amongst providers is also pivotal in terms of medication safety. So I hope that we'll have better interoperability. But I think there's so much more opportunities for improvement. So yeah, so that would be my magic wand. I think there's a lot of wand waving in that one. Sorry, Pat.
Yeah, well, Pat, so the top of my wish list or the aspirational goal is that every individual who needs to take medications has a system built around them specific to what they need. You may not need four different practitioners helping you, but sometimes you do. You heard about all these resources that are available. Why aren't we all working together as healthcare professionals in a community to meet your needs and listen to what you need the most and make sure that you are confident taking medications? That's the goal for my goal for the future.
I think for me, it's actually a desirable goal would be to have more legislature mandate around these processes in place. I think that's never the answer, right? That's not going to be the solution to the problem. But what we do know is when there is a requirement for things like medication reconciliation at transitions of care, the programs will come and the resources will come and the reimbursement will come for the folks who are trying to do the good work that we're doing. Until that happens, we're going to struggle with the programs being comprehensive and connected. And I think that's been a journey for all of us in the individual spaces that we work in right now.
Thank you. And thank you so much for sharing your wisdom and your encouragement for everyone to really take advantage of these tools that are available, these resources, and to be knowledgeable, to ask the why. Why am I taking this? Why can't I reduce this? Again, thank you all for being here. And I'm going to turn it over to Nancy to close us out.
You're muted, Nancy.
Okay,
There you go.
Yay.
thank you, Pat. You did just a terrific job moderating it. The speakers were spectacular. I learned so much, and I really appreciate that. Thanks again to the Upper Midwest Telehealth Resource Center for hosting this. We could not have done it without you. Thanks to Pat, and thanks to the supporting organizations who have publicized this event, including the Illinois Office of Broadband, Egyptian Area Agency on Aging, Connected Health Initiative, and Age Options. I want to let you know that there's a recording of this event that will be available on our website, and we will send it out to all the attendees. So, what you want to listen to a second time, you can listen to a second time. And we welcome any questions that you have. We're thrilled that telehealth can enable the improvement of medication care for patients, and it's one of the great things that broadband is doing for the state of Illinois and the whole region. So thank you very much.
Okay, with that, I think we're going to close it out.
Thank,
Oh, sorry, Pat.
thank you, Danielle, for all your help. And I agree, the Broadband Illinois Initiative, as well as the Upper Midwest Telehealth Resource Center are really, they're not-for-profit organizations. Telehealth, Upper Midwest and Telehealth is a program of the supported by the federal government for rural as well as yeah, areas that also need resources. So again, thank you so much for joining us and for hosting us. Thank you.
Thank you both so much, and thanks to our attendees. As was said before, this is going to be available online, the recording. We'll also send out the slides if they're requested. Thank you so much for joining us today. If you have questions that you weren't able to ask your speakers, we will be able to connect you with them. But thank you again for attending this wonderful presentation. With that, I am going to close things, but thank you all so much. Have a great afternoon and enjoy the rest of your week.
Thank you.
Thank you.
Of course.